Hello, and welcome to Session 3 of the CE program, Navigating Pain Management, Safe Opioid Prescribing, and Opioid Use Disorder, brought to you by Southern Illinois University Edwardsville and the Illinois Prescription Drug Monitoring Program. Today, we'll be focusing on the non-opioid analgesics and adjuvants. My name is Chris Herndon. I'm a professor with the School of Pharmacy at Southern Illinois University Edwardsville, as well as a clinical associate professor with the St. Louis University School of Medicine. In accordance with CME and CPE regulations, please find financial disclosures here on this slide. We have just two learning objectives for this 30-minute module. One, recognize non-opioid analgesic modalities with evidence supporting their use in both acute and chronic pain. Our second learning objective is to anticipate and manage common adverse effects in non-opioid analgesics as part of the pain treatment plan. While we only have two learning objectives, we have a ton to cover in 30 minutes, so strap yourself in and here we go. So historically speaking, we referred to medications that could be used for their acute anti-nociceptive effects as analgesics, while those medications that were used either synergistically or for chronic neuropathic pain as adjuvant analgesics. Given the progress in our understanding of nociception and of hyperalgesia, I find it's much easier to just refer to these classes of medications as non-opioid analgesics. These include acetaminophen, non-steroidal anti-inflammatory drugs, skeletal muscle relaxants, NMDA neuromodulators, many of our antidepressants, anticonvulsants, local anesthetics, and somewhat controversially, cannabis. While the actual review of the supporting evidence for each of these drug classes is beyond probably our allotted time today, I'll do my very best to keep my evidence-based medicine hat on and share when you should put yours on as well. There may be some instances where non-FDA-approved indications are being discussed, and I will also try to do my best to mention those as we get to them. We might as well start off with an old, tried-and-true non-opioid analgesic, acetaminophen. Acetaminophen seems to inhibit both cyclooxygenase 1 and cyclooxygenase 2, although only in the central nervous system, thus its limited anti-inflammatory effects. Its active metabolite, AM404, appears to, believe it or not, be a weak agonist of the two cannabinoid receptors, CB1 and CB2. Anytime I discuss acetaminophen, I always try to implore the listeners to try and avoid using abbreviations or jumping between names due to the potential confusion for patients and the risk of acetaminophen overdose. This risk has dropped significantly since the FDA limited the amount of acetaminophen in combination products to just 325 milligrams per dose. Contrary to popular belief, acetaminophen is not a completely benign drug. Most of us are familiar with the risk of hepatotoxicity, especially at higher doses. However, other drug effects are associated with acetaminophen that include risk of Stevens-Johnson syndrome, some coagulopathies, and in very rare circumstances, nephropathy. Drug interactions do exist with this drug, especially from an additive hepatotoxicity standpoint. Interestingly, JAMA, or the Journal of the American Medical Association, published a study back in 2006 by Paul Watkins in which healthy adults received 4 grams of acetaminophen daily or placebo for 14 days straight. Liver transaminases were followed daily from baseline out to day 21, so approximately 1 week after discontinuation of daily dosing. While the placebo arm exhibited no transaminase elevations whatsoever, those in the acetaminophen arm had clinically and statistically significant elevations in alanine aminotransferase. While most acetaminophen toxicity is associated with supertherapeutic doses or prolonged exposure, risk does exist in other situations as well. For instance, acetaminophen is metabolized through sulfation, glucuronidation, and cytochrome P450 1A2. When competitive inhibition of glucuronidation is present, metabolism may actually be shunted away from glucuronidation towards the CYP or CYP enzyme pathway, which can yield increased levels of the hepatotoxic intermediary metabolite NAPQI. When the liver is functioning appropriately in non-fasting states, glutathione quickly converts NAPQI to a more polar, less toxic endpoint that limits the risk to the liver. In fasting situations, or when CYP1A2 is induced by drugs or those hyperfunctional or rapid metabolizers for CYP1A2, glutathione may actually become saturated, increasing hepatic exposure to NAPQI. The actual maximum dose of acetaminophen has also been somewhat controversial, with the FDA maintaining its 4 gram per day max dose, while the American Liver Foundation and several other professional organizations have come out and recommended a more conservative 3 grams per day. Older patients and those at increased risk of hepatotoxicity should likely limit their daily intake of acetaminophen to probably no more than 2 grams per day. The systemic NSAIDs are probably our most widely utilized workhorses of the non-opioid analgesics in pain management. Currently, there are 19 commercially available NSAIDs on the U.S. market, not including the topical products. These NSAIDs can be further categorized by their respective chemical classes, and some propose that these different classes differ sufficiently enough to be considered unique treatment modalities when others are poorly tolerated or potentially ineffective. We've all encountered a patient in our practice that has informed us that NSAIDs either don't work or they cause adverse effects. Although the only 2 NSAIDs that have been tried in these folks may be the propionic acids naproxen or ibuprofen, still the patients are relatively set in their decision. My advice is don't be too quick to discard NSAIDs altogether if 1 or 2 of these drugs is either poorly tolerated or ineffective. A deeper look into these agents will also show that significant potency differences may also play a role in both tolerability and efficacy. For instance, the non-acetylated salicylate salsylate is actually almost 1/10 the potency of ibuprofen, while similar milligram to milligram doses are actually used clinically. Another way I'd like for you to consider the NSAIDs is by their relative potency in inhibiting the cyclooxygenase enzymes. Remember that COX-1 tends to be homeostatic, with downstream prostaglandins being responsible for GI protection, renal perfusion, and platelet aggregation. COX-2 appears to be more inducible, with its downstream prostacyclins responsible for inhibition of platelet aggregation, renal perfusion, and notably angiogenesis. In fact, this may be part of the reason why higher risk of cardiovascular events were seen with the selective COX-2 inhibitors, such as rofecoxib. Today, all of the true selective COX-2 inhibitors have been removed from the U.S. market, with COX-2 preferential NSAIDs remaining, such as atodolac, meloxicam, and celecoxib. There does not appear to be a significant impact on analgesic or anti-inflammatory effect of these agents depending on their relative COX-1 or COX-2 specificity. However, differences in adverse effects may definitely be noted. In fact, we do see an increased risk of NSAID-associated upper gastrointestinal bleeding the more COX-1 selective an NSAID is. You'll notice here that the relative risk of GI bleed is almost twice as high for naproxen as compared to celecoxib or diclofenac. We can't really talk about NSAIDs without talking about GI bleed risk and the potential risk factors. Most of these risk factors are well known and clinically intuitive. However, newer data suggests that when SSRIs or SNRIs are given concurrently with NSAIDs or other platelet-active agents, the risk of GI bleed increases dramatically. Prophylaxis of NSAID-induced GI bleed is reasonable in those at higher risk in whom no other treatment options exist. Only proton pump inhibitors and misoprostol have been shown to prevent these bleeds, although there is some data to suggest that high-dose H2 antagonists may offer some protection, and this stems from the combination product of ibuprofen and high-dose famotidine. Potentially the muddiest adverse effect of the NSAIDs is the increased risk of cardiovascular events. Large retrospective cohort studies suggest that the more COX-2 selective an NSAID, the corresponding higher the risk of adverse cardiovascular outcomes. Based on this data, several of the large professional organizations provided position statements or guidelines on the use of NSAIDs in those with ischemic heart disease or at elevated risk of cardiovascular events. As you can see here, the American Heart Association actually came off the fence with suggestions that naproxen may pose the lowest risk in the general population, and that when NSAID use is absolutely necessary in someone with existing heart disease, the non-acetylated salicylates should be considered before the non-selective NSAIDs and ultimately before the COX-2 selective NSAIDs. Remember, the non-acetylated salicylates include salicylate and diflunisal. So with all of that said, let's flash forward to 2016, where Dr. Neeson published the first prospective randomized controlled trial comparing the non-selective NSAIDs naproxen and ibuprofen to the COX-2 preferential celecoxib. Here, the investigators found that celecoxib was non-inferior to either naproxen or ibuprofen in terms of composite cardiovascular outcomes, but had a lower rate of serious GI adverse events. Now, there are a number of caveats in the interpretation of this study. First, the study was funded by Pfizer, the manufacturer of brand name celecoxib at the time of publication. Also, a more careful look at the dosing of all three arms may somewhat limit external validity of the study. Unfortunately, the results of this study really threw a monkey wrench into our understanding of the cardiovascular risks of NSAIDs and being able to assume linear risk relationships as the COX selectivity changes. NSAIDs can impact renal function regardless of cyclooxygenase specificity. Nephrotoxicity can occur either via direct tubular insult, resulting in interstitial nephritis, or via hemodynamic changes in glomerular filtration and pressures. In the healthy kidney, NSAID-induced afferent arterial constriction can result in activation of the RAS system with mild elevations in blood pressure. In those with pre-existing renal compromise, reduced renal perfusion, or in cases of hypovolemia, this change in GFR can become pronounced, leading to acute kidney injury. Monitoring serum creatinine when NSAIDs are used chronically is important, and KDIGO guidelines recommend limiting exposure to NSAIDs when creatinine clearance falls below 60 milliliters per minute and avoiding NSAIDs when at all possible when the creatinine clearance falls below 30 mils per minute. The skeletal muscle relaxants are basically divided into antispasmodics, spasmolytics, and direct-acting relaxants. I kind of have a love-hate relationship with this class of medications. The evidence to support their use long-term is really scarce, and they are really not without potentially serious adverse effects, especially when combined with opioid analgesics. However, they also provide a valuable non-opioid tool in the toolbox, and many patients anecdotally find benefit from these agents. While most of the patients referred to our service come to us on cyclobenzaprine, we tend to prefer baclofen and tizanidine given their slightly more robust evidence base. For the most part, these meds are extremely sedating, which may be the only reason a subset of patients find them so beneficial. Remember that cyclobenzaprine is essentially a tricyclic antidepressant, with its structure differing from amitriptyline by only one double bond. So let's dive a little bit deeper into the skeletal muscle relaxants. You'll notice that most, if not all, skeletal muscle relaxants demonstrate the side effects of sedation and anticholinergic burden. It's also important to remember that concurrent use of skeletal muscle relaxants with opioids does increase the risk of opioid-related respiratory depression and opioid overdose. Currently, we do not have data to assess the risk differences between the individual skeletal muscle relaxants, so that kind of creates a little bit of confusion in terms of how safe they really are. A couple of quick clinical pearls that I use daily in our practice. One, baclofen, while one of my very favorite agents in this class, can create a serious and potentially fatal withdrawal syndrome when it's abruptly discontinued. While this has primarily been reported in patients receiving baclofen intrathecally, the risk of this syndrome should be considered when doses are adjusted downward, even when the oral formulations are being used. We tend to really pay close attention to this when we have patients up at the maximum dose of baclofen of 80 milligrams per day. Carisoprodol is metabolized to meprobamate, which is a barbiturate. Considering this, the abuse liability of this particular medication appears significantly higher than others in the same class and likely led to its scheduling from a DEA standpoint. Additionally, patients on carisoprodol may screen positive for barbiturates on urine drug screening. Remember that carisoprodol, like barbiturates, should be weaned slowly to prevent withdrawal seizures. While we don't use this drug clinically, I recommend for prescribers that do still prescribe this drug to make sure that no other controlled substances are being taken concurrently to reduce risk. Tizanidine is another fan favorite with a slightly larger database supporting its use beyond acute musculoskeletal pain. It does have positive long-term data in the treatment of cervicogenic headache prevention and diabetic peripheral neuropathy, believe it or not. And this is likely owing to its centrally acting alpha-2 agonism. This mechanism of tizanidine also contributes to its transient blood pressure lowering effects that must be considered when initiating or titrating this particular drug. We also need to make sure absolutely that we educate patients on the risks of rebound hypertension if tizanidine is abruptly discontinued. Elevated liver transaminases have been associated with tizanidine, so periodic monitoring is often recommended. In our clinical practice, we tend to look at methocarbamol next should baclofen or tizanidine be either poorly tolerated or ineffective. Methocarbamol is typically well tolerated at lower doses but may cause urinary discoloration, which can be distressing to patients if they're not warned about this beforehand. We generally tend to avoid chlorzoxazone due to poor tolerability and the risk of hepatotoxicity. Metaxalone was originally launched as a less sedating alternative to the other skeletal muscle relaxants. And while this may be true, it's also likely the least effective of this class, with most patients reporting back that they perceive very little benefit when we do try this medication. One skeletal muscle relaxant that is especially intriguing and that we have been incorporating more frequently in our practice is orphenadrine. Orphenadrine causes a significant amount of sedation, likely owing to its histamine 1 effects. It has also been shown to have mild NMDA glutamate receptor antagonism, which may be a promising mechanism when considering its use long-term. The anticholinergic burden of orphenadrine is quite high, and my clinical experience is that patients generally have a tough time tolerating this drug. It's really interesting from a historical perspective that orphenadrine was actually originally launched and marketed as an analgesic and not as a skeletal muscle relaxant. While dantrolene, diazepam, and Botox are listed here, we don't use dantrolene as it's really only indicated for malignant hyperthermia or neuroleptic malignant syndrome. Botox is reserved in our clinic for chronic migraine prevention, and diazepam is avoided altogether as a muscle relaxer due to its misuse liability. If you'll recall, the N-methyl D-aspartate glutamate receptor, or NMDA, is one of the 3 postsynaptic glutamate receptors that serve as calcium channels. NMDA receptors are depolarization dependent, which means the excitatory postsynaptic potential must already be underway via AMPA receptors before the magnesium plug is unlodged from the channel when glutamate and glycine are both docked allosterically. As we believe that NMDA plays some role in central sensitization and also potentially the chronification of pain, it makes a potentially attractive target for pharmacotherapy aimed at anti-nociception. Some of the commercially available drugs that have exhibited some level of antagonism at the NMDA receptor include dextromethorphan, ketamine, methadone, memantine, amantadine, felbamate, levorphanol, and orphenadrine. Ketamine has recently garnered a significant amount of attention as a treatment modality for both acute and chronic pain. In fact, ketamine use in acute pain guidelines were actually just released not too long ago. Positive long-term data on anti-nociception does exist in varying levels of quality for all of the medications listed here on this slide. So to dive a little deeper into NMDA binding, listed here you'll see a number of analgesics with their respective NMDA binding affinities. Levorphanol, which is structurally similar to dextromethorphan, possesses the highest binding affinity for the NMDA glutamate receptor based on the data reviewed. For most of these agents demonstrating NMDA activity, psychotomimetic side effects can be seen at higher dosing levels. Given the extremely high co-occurrence of anxiety and depression in persons experiencing chronic pain, the antidepressants make an incredibly attractive treatment modality as adjuvant analgesics. The tricyclic antidepressants, or TCAs, likely have the largest evidence base to support their use, primarily in neuropathic pain syndromes. All of the TCAs have some amount of positive data, with the highest quality data being reserved for amitriptyline, nortriptyline, desipramine, and imipramine. Remember back from pharmacology that there are tertiary and secondary amine tricyclic antidepressants. Tertiary TCAs have higher lipophilicity and likely higher CNS penetration. This additionally is thought to contribute to higher side effect burden, especially anticholinergic side effects. For instance, nortriptyline is the secondary amine active metabolite of amitriptyline, and desipramine is the secondary amine active metabolite of imipramine. In diabetic peripheral neuropathy, studies suggest that secondary amine TCAs are better tolerated with comparable efficacy profiles to their tertiary counterparts. More recent studies, however, have suggested that there may not actually be a significant difference in tolerability between these two subclasses. Remember, these agents may cause QT prolongation, and this should be judiciously considered during use. In fact, the American Psychiatric Association recommends baseline ECGs prior to the initiation of a TCA in anyone over the age of 50. However, I wonder if this is likely a recommendation based on dosing required for antidepressive or anxiolytic effects, which are much, much higher than what we typically use for adjuvant analgesia and migraine prevention. The TCAs are listed here in order of their antihistaminergic potency, with desipramine demonstrating the lowest H1 activity and doxepin exhibiting the highest H1 activity. This may partially explain the vast differences in sedative effects between these two agents. Now, coming to the SNRIs. The SNRIs are the bee's knees, so to speak, in terms of adjuvant analgesia. These agents have dosing profiles similar for both anti-nociception as well as anxiety and depression. The SNRIs with the largest databases supporting studies in pain are venlafaxine, duloxetine, and milnacipran. Desvenlafaxine, an active metabolite of venlafaxine, should likely be expected to possess similar adjuvant analgesic effects. However, the data is just not there to make that claim. Duloxetine has largely replaced venlafaxine as kind of the go-to SNRI in the treatment of chronic pain. Both of these agents can transiently increase blood pressure, and venlafaxine can be somewhat activating, whereas duloxetine can cause somnolence or insomnia. Duloxetine does require periodic liver transaminase monitoring, although I have not ever been able to find clear recommendations on how necessary it is to do transaminase monitoring at baseline or how frequently it should occur. Milnacipran is somewhat of a different animal in that it has some preference for norepinephrine over serotonin, and this is approximately 3-fold higher. It also may cause transient increases in blood pressure and may require liver transaminase monitoring. This medication is currently only FDA approved for the treatment of fibromyalgia, where its levorotary enantiomer levomilnacipran is only FDA approved for depression. While the SSRIs have largely been disappointing in clinical trials assessing their utility in neuropathic pain syndromes, 2 do stand out possessing at least some positive data in RCTs. Paroxetine, the most sedating of the SSRIs, does have one positive RCT study in diabetic peripheral neuropathy. Remember, this agent has an extremely short half-life, requiring a controlled release dosing form. Missed doses of paroxetine may result in a somewhat uncomfortable serotonin withdrawal, which can be fairly distressing for patients. We try to avoid paroxetine in women of childbearing age due to the teratogenicity associated with its use in the first 22 to 23 weeks of gestation. The other SSRI listed here, escitalopram, was shown to be non-inferior to duloxetine in one small randomized controlled trial for radicular low back pain. Remember that while we don't have data for citalopram and escitalopram in pain at this point, both of these drugs may prolong QT intervals, and this is reflected in dose reduction recommendations once patients hit the age of 65 years. The atypical antidepressants are largely either ineffective for pain syndromes that they've been studied in, or have low-quality studies supporting their use. Bupropion, perhaps the most activating of the antidepressants, does have one double-blind placebo-controlled randomized study supporting its use in diabetic peripheral neuropathy. Remember, bupropion should be avoided in patients with a history of seizure disorder, and it may contribute to weight loss and increased impulsivity. It does demonstrate potent CYP2D6 inhibition, which should be a consideration before prescribing. We use bupropion occasionally as an adjuvant analgesic, especially in patients with fibromyalgia that either do not have anxiety or their anxiety is well controlled prior to start. Trazodone doesn't necessarily have positive data in pain as a monotherapy, but when you combine trazodone with pregabalin, it shows improved sleep and pain scores for those with fibromyalgia syndrome, more so than pregabalin alone. Some overarching considerations I want to make sure we hit on is that the SSRIs and the SNRIs as a class can cause clinically relevant hyponatremia, and when combined with platelet-active meds like NSAIDs, can increase the risk of upper gastrointestinal bleeding. We make it a point to follow up within 2 weeks for any patient we start on an antidepressant, regardless of the indication for which we're starting it. The anticonvulsants have also proven to be effective tools in the treatment of pain, especially chronic neuropathic pain syndromes and nociplastic pain syndromes. The first-generation anticonvulsants with positive data include carbamazepine and valproic acid. We rarely use valproic acid any longer outside of those with co-occurring bipolar disorder. We avoid this drug like a wet dog in patients of childbearing potential due to its teratogenicity. It also has been associated with significant weight gain and metabolic disturbances to include polycystic ovaries, insulin resistance, and hyperammonemia. Valproic acid does require therapeutic drug monitoring, although ideal serum levels have really never been correlated with its anti-nociceptive or migraine prevention effects. Carbamazepine is perhaps the oldest adjuvant analgesic given its indication for trigeminal neuralgia, or tic douloureux, for many decades. Carbamazepine, while extremely effective, is also quite cumbersome to prescribe and to monitor. Carbamazepine is associated with hyponatremia, Stevens-Johnson syndrome, and aplastic anemia. It's a very potent cytochrome P450 enzyme inducer, and it's also an auto-inducer, meaning it can induce its own metabolism in addition to numerous other drugs. Carbamazepine requires therapeutic drug monitoring, primarily for the avoidance of toxicity. Like valproic acid, no correlated serum concentrations have been identified with its anti-nociceptive efficacy. We in our clinic tend to reserve carbamazepine as a last-line option when we have moved through all of the other anticonvulsants as adjuvants. The second and third generation anticonvulsants are used frequently as adjuvant analgesics. Probably the most well-recognized and best supported by data are the gabapentinoids gabapentin and pregabalin. Both of these agents inhibit the alpha-2 delta subunit of the presynaptic calcium channel. Gabapentin has saturable kinetics, limiting both its absorption in the GI lumen as well as its ability to cross the blood-brain barrier. To combat this issue, 2 products have been developed and are commercially available which purport to reduce the impact of gabapentin's saturable kinetics. One is a long-acting formulation, while the other is a type of prodrug. Gabapentin, as well as pregabalin, requires renal dosing and may cause neurocognitive side effects, especially in older adults. Sedation and edema are also a risk with both of the gabapentinoids. Data is emerging that suggests that both of these drugs may possess some abuse liability, especially when administered concurrently with opioids. Also of concern in the same vein is that gabapentinoids may increase the risk of opioid-induced respiratory depression and opioid overdose. Topiramate and zonisamide are both interesting anticonvulsants for consideration in the treatment of pain. Both drugs share similar pharmacology that includes sodium channel inhibition, calcium channel inhibition, AMPA glutamate inhibition, and carbonic anhydrase inhibition. This last mechanism of action, the carbonic anhydrase inhibition, likely contributes to both drugs' risk of nephrolithiasis and metabolic acidosis. Both agents have positive data in radicular low back pain, migraine prevention, and diabetic peripheral neuropathy, although topiramate registration studies for this last indication were largely negative. We also use oxcarbazepine and lamotrigine in our clinical practice despite somewhat equivocal RCT studies. Oxcarbazepine is structurally similar to carbamazepine and shares many of its negative attributes, with the exception of the need for therapeutic drug monitoring. Oxcarb can still cause hyponatremia, although to a lesser extent. It may cause aplastic anemia, although to a lesser extent, and may cause SJS, again, although to a lesser extent. Lamotrigine is probably best known for its titration-dependent risk of Stevens-Johnson syndrome. Slower titration schedules have largely reduced the risk of SJS with lamotrigine to that of its peers. Lamotrigine has been studied in numerous chronic pain syndromes, with HIV neuropathy and spinal cord injury-related pain being the only studies that showed robust positive results. Last but not least, one of the most controversial adjuvant analgesics is cannabis. We could talk about cannabis's utility for pain management for this entire session. Cannabis has been well studied in varying dosage forms, administration routes, and in different cannabinoid expressions. The studies have been largely equivocal, unfortunately, although it's very difficult to make comparisons between pain syndromes and between cannabis types. In general, agonism of the centrally expressed CB1 cannabinoid receptors results in downstream inhibition of sodium and calcium channels, thus limiting presynaptic depolarization. Several drugs are actually being investigated that inhibit the reuptake of naturally occurring cannabinoids, such as anandamide and 2-AG. And as more states open the doors to cannabis use, either medically or recreationally, I would expect more data should become available in which to make better informed decisions by us, the clinicians. It's also important to note that for those of us working in the pain management world, that positive cannabis results on urine drug screens should still be addressed from a medico-legal standpoint. For instance, when Illinois legalized recreational cannabis, our clinic really struggled somewhat with how to address this in our pain management agreements and our monitoring strategies. For a little while, we just ordered our urine drug screens without THC. And I think it's important to share with all of you that I was actually warned by an attorney who specializes in defending pain management providers that this is in fact very risky and that any unexpected findings on urine toxicology reports should be addressed in the chart note. In conclusion, non-opioid and adjuvant analgesics are very useful treatment modalities for patients who experience pain. Unfortunately, we often toss the entire drug class out when one or two agents are either ineffective or poorly tolerated. Having a detailed monitoring plan when initiating and titrating these agents will help clinicians avoid negative drug-related outcomes. I truly hope that you have found Session 3 of Navigating Pain Management, Safe Opioid Prescribing, and Opioid Use Disorder to be enjoyable. Again, thank you to our sponsor, the Illinois Prescription Drug Monitoring Program, for making this freely available CE program accessible